We will see about allergic conjunctivitis. There are many types of allergic conjunctivitis. The first type, let's see about simple allergic conjunctivitis. It's a mild non-specific allergic conjunctivitis characterized by itching, hyperemia, mild papillary response. Etiology, it is a type 1 immediate hypersensitivity reaction mediated by IgE, subsequent mast cell activation, and family history of atopy may be present. Simple allergic conjunctivitis is known to occur in two forms: seasonal allergic conjunctivitis and perennial allergic conjunctivitis. SAC, seasonal allergic conjunctivitis, and perennial allergic conjunctivitis. Seasonal allergic conjunctivitis is a response to seasonal allergens such as tree, grass, pollens, etc. It is of very common occurrence, may associate with hay fever, allergy rhinitis, and also known as hay fever conjunctivitis. It manifests as acute allergic conjunctivitis, and PAC is a response to perennial allergens such as house dust, animal dander, and mite. Condition is chronic in nature, occurring all through the year. Pathological feature comprise of simple allergic conjunctivitis comprise of vascular, cellular, conjunctival responses. Vascular response is characterized by sudden and extreme vasodilation. Increased permeability of vessels lead to exudation. Cellular response is in the form of conjunctival infiltration, exudation, and discharge of eosinophils, plasma cells, and mast cells, producing histamine-like substances. Conjunctival response is in the form of boggy swelling of conjunctiva followed by increased connective tissue formation and mild papillary hyperplasia. Clinical features: symptoms: intense itching and burning sensation in the eyes associated with watery mucus, stringy discharge, and mild photophobia. Signs: hyperemia and chemosis, which give a swollen, juicy appearance to conjunctiva. Mild papillary reaction may be seen on palpable conjunctiva. Edema of lids is often present. Diagnosis: typical symptoms and signs: normal congenital flora, presence of abundant eosinophil in the discharge. Treatment: elimination of allergens if possible. Topical vasoconstrictors like nafazoline, antizolline, tetrahydrozoline provide immediate decongestion. Artificial tears like carboxymethylcellulose provide soothing effect. Mast cell supplies such as sodium chromoglycerate, nidochromal sodium are effective in preventing recurrence in atopic cases. Dual-action antihistamines and mast cell supplies such as agilastine, olopatadine, phytodiphen are very effective in exacerbation. Steroid eye drops should be avoided. It may be prescribed for short duration. Systemic antihistamine drugs are useful in acute cases with marked itching. Desensitization has been tried without much rewarding results. However, a trial may be given. Vernal keratoconjunctivitis or spring catarrh. VKC is a recurrent bilateral interstitial self-limiting allergic inflammation of conjunctiva having periodic seasonal incidents. Vernal keratoconjunctivitis has long been considered as an atopic disorder, mainly type 1 IgE mediated hypersensitivity reaction to pollen allergens. However, now it is believed that pathogenesis of VKC is characterized by Th2 lymphocyte alteration, and that is exaggerated IgE response to common allergens is a secondary event. Predisposing factor: age and sex, 4 to 20 years, more common in boys than girls. Season: more common in summer, hence the name spring catarrh seems to be a misnomer. It's a warm weather conjunctivitis. Climate: more prevalent in tropics, less in temperate zones, and almost non-existent in cold climate. Pathology: congenital epithelium undergoes hyperplasia and sends downward projection into subepithelial tissue. Adenoid layer shows marked cellular infiltration by eosinophils, plasma cells, lymphocytes, and histiocytes. Fibrous layers show proliferation, which later on undergoes silent changes. Congenital vessels also show proliferation, increased permeability, and vasodilation. Clinical features: symptoms: spring catarrh is characterized by marked burning and itching sensation, which is usually intolerable and accentuated when patient comes in a warm, humid atmosphere. Itching is more marked with palpable form of disease. Other associated symptoms are photophobia, lacrimation, stringy discharge, and heaviness of lids. Signs of vernal keratoconjunctivitis can be described in the following three clinical forms: palpebral form, Usually upper tarsal conjunctiva of both eyes is involved. Typical lesion is the presence of hard, flat-topped papillae arranged in a cobblestone or pavement stone fashion, along with conjunctival hyperemia. In severe cases, papilla may be hypertrophy to produce cauliflower-like excrescence of giant papillae. Congenital changes are also associated with white trophy discharge. Palpable form of vernal keratoconjunctivitis. Bulbar form of VKC depicting gelatinous membrane around the limbus. Tranthouse spots at limbus. Cobblestone papillae and hexagonal papillae, gelatinous limbal membrane, Tranthouse spot, dusky red triangular congestion. Bulbar limbal form, dusky red triangular congestion of bulbar conjunctiva in palpable area, gelatinous thickened accumulation of tissue around the limbus, and the presence of discrete whitish raised dots along the limbus or Tranthouse spots. Vernal keratopathy, shield ulcer, vernal corneal plaque, mixed form. It shows combined features of both bulbar and bulbar forms. Vernal keratopathy, corneal involvement VKC may be primary or secondary due to extension of limbal lesions. Corneal involvement VKC may be primary or secondary due to extension of limbal lesions. Vernal keratopathy is most frequent with palpable form and includes following 5 types of lesion. Punctured epithelial keratitis, ulcerative vernal keratitis, vernal corneal plaques, subepithelial scarring, and pseudo gerontoxin, and it is involving upper cornea, is usually associated with palpable form of disease. The lesions always stain with rose bengal and invariably with fluorescent dye. Shield ulceration present as shallow transverse ulcer in upper part of cornea, and the ulceration result due to epithelial macroerosions. It is a serious problem which may be complicated by bacterial keratitis. Vernal corneal plaques result due to coating of bare areas of epithelial macroerosion with a layer of altered exudates. Subepithelial scarring occurs in the form of ring scar. Pseudo gerontoxin can develop in recurrent limbal disease and is characterized by classical Cupid's bow outline. Clinical course of disease is often self-limiting and usually burns out spontaneously after 5 to 10 years. Differential diagnosis. Palpable form of VKC needs to be differentiated from trachoma with predominant papillary hypertrophy. Topical anti-inflammatory therapy. NSAIDs, antihistamines, mast stabilizers, etc. can be given. Topical steroids. These are effective in all forms of sphincter. However, their use should be minimized as they frequently cause steroid-induced glaucoma. Therefore, monitoring of intraocular pressure is very important during steroid therapy. Frequent instillation should be followed by maintenance therapy for 4 times a day for 2 weeks. Commonly used steroid solutions are of fluoromethalone, medrisone, betamethasone, dexamethasone, medrisone, fluoromethalone, etc. Mast cell stabilizers should also be given. Sodium bromide 2% drops 5 times a day. Dual action antihistamines, azilastine, olopatine, ketotifen, etc. NSAIDs eye drops such as ketorolac, diclofenac give additional benefits. Topical cyclosporine, the immune modulator, is indicated when steroids are ineffective, inadequate, or poor tolerated, or when given as steroid sparing agent in patients with severe disease. Tacrolimus is another immune modulator which can be useful in refractory cases. Topical rubricating and mucolytics, artificial tears, methylcellulose, acetylcysteine used topically as mucolytic properties and useful in treatment of early plaque formation. Systemic therapy. Oral antihistamine may provide some relief from itching in severe cases. Oral steroids for a short duration have been recommended for advanced to very severe non-response cases. Treatment of large papillae. Very large papillae can be tackled either by supratarsal injection of long-acting steroid or cryoablation, or surgical excision is recommended for extraordinary large papillae. General measures include Dark goggles to prevent photophobia. Cold compress ice packs have soothing effect. Change of place from hot to cold area is recommended for recalcitrant patients. Desensitization also to be tried. Treatment of vernal keratopathy. Punctured epithelial keratitis requires no extra treatment except instillation of steroids. Large vernal plaque requires surgical incision. Severe shield ulcer result due to assistance to medical therapy may need surgical treatment in form of debridement. Superficial keratectomy, excimer laser therapeutic keratectomy, as well as amniotic membrane transplantation to enhance reepithelialization. Atopic keratoconjunctivitis. It can be thought of an adult equivalent of vernal keratoconjunctivitis. Most of the patients are young atopic adults. AKC, both IG and cell-mediated immunity plays a role. Type 1 as well as type 4 hypersensitivity reactions are responsible for inflammatory changes of conjunctival cornea. Symptoms include itching, soreness, dry sensation, mucoitis, photophobia, etc. Signs, eyelid signs are lid margins are chronically inflamed with rounder posterior borders. Extra lid folds may occur due to chronic eyelid rubbing. Loss of lateral eyebrows may be seen. Congenital sign, tarsal conjunctiva has milky appearance. There are very fine papillae, hyperemia, scarring with case. Bulbar conjunctiva is chemos and congested. Limbal conjunctiva may show gelatinous deposits and trantas dots as seen in VKC. Corneal signs, punctuate epithelial erosion may often severe and lower half of the cornea may be seen. Persistent epithelial defects sometimes associated with focal thinning can also occur. Plaque formation may also occur similar to VKC. Peripheral vascularization, stromal scarring are more common than VKC. Associations, keratoconus is associated with in about 15% of cases. Atopic cataract in the form of anterior posterior subcapsular opposition may be associated. Retinal detachment incidence is more higher than general public. Clinical course like dermatitis eczema with which is associated. AKC is a protracted course with exacerbation remissions. Like vernal keratoconjunctivitis, it tends to become inactive when patient reaches the 5th decade. Treatment of AKC exactly same lines are described as VKC, steroids, etc. Mast cell stabilizers and other drugs. Lid margin inflammation, facial eczema should be treated with oral NSAIDs, oral antibiotic, doxycycline, azithromycin, and local application of steroids and antibiotic agents. Giant papillary conjunctivitis. It's a mechanically induced papillary conjunctivitis, a localized allergic response, physically rough or deposited surface, contact lens, prosthesis, exposed nylon switches, scleral buckle. Probably it is a sensitive reaction to components of plastic leached out by action of tears. Symptoms, itching, stringy discharge, reduced wearing time of contact lens or prosthetic shell. Papillary hypertrophy of the upper tursal conjunctiva similar to that seen in pulpal form VKC with hyperemia are the main stages. Main signs. Treatment, offending cause should be removed. After discontinuation of contact lens or artificial eye or removal of nylon switches, the papilla resolve over a period of 1 month. Mast cell stabilizers such as sodium chromoglycerate is known to relieve the symptoms and enhance the rate of resolution. Combined antihistamine and mast cell stabilizer like azilastine, olopatadine are very effective. Steroids may require in the restant cases. Flectinola keratoconjunctivitis. It is a characteristic nodular affection occurring as an allergic response of the conjunctival and corneal epithelium to some endogenous allergen to which they have become sensitized. Flectinola conjunctivitis is worldwide distribution, however it is incidence higher in developing until etiology. Type 4 hypersensitivity, delayed hypersensitivity mediated response to endogenous microbial proteins and the microbial allergic conjunctivitis. Causation, tuberculous proteins were considered previously as common cause. Staphylococcus proteins are also cause. Other allergens may be present as Moraxilla axonfil bacillus, certain parasite. Predisposing factors, age, higher in girls, incidence, undernourishment, living condition, overcrowded and hygiene. Season, it occurs in all climates but incidence is high in spring and summer season. Pathology, stage of nodule formation. In this stage there occurs exudation and infiltration of leukocytes to deeper layers of conjunctiva leading to nodule formation. Central cells are polymorphonuclear and peripheral cells are lymphocytes. The neighboring blood vessels dilate and their endothelium proliferates. Stage of ulceration. Later on, necrosis occurs at the apex of the nodule and an ulcer is formed. Leukocyte infiltration increases plasma cells and mast cells. Stage of granulation. Eventually, floor of the ulcer becomes covered with granulation tissue. Stage of healing. Healing occurs usually with minimal scarring. Symptoms. Clinical features. Symptoms in simple flectinolar conjunctivitis are few, like mild discomfort in eye, irritation and reflex watering. However, usually there is associated mucopurulent conjunctivitis due to secondary bacterial infection. Simple flectinolar conjunctivitis, it is the most common seen variety. It is characterized by the presence of typical pinkish white nodules surrounded by hyperemia and bulbar conjunctiva, usually near the limbus. Most of the times there is alternate nodule, but at times there are maybe two nodules. In few days, the nodule ulcerates at the apex, which later on gets epithelialized. Rest of the conjunctiva is normal. Necrotizing flectinolar conjunctivitis is characterized by presence of very large flectin with necrosis and ulceration leading to severe pustular conjunctivitis. Miliary flectinolar conjunctivitis is characterized by presence of multiple flectins which may arrange haphazardly or in the form of ring around the limbus, may even form a ring ulcer. Flectinolar keratitis corneal involvement may occur secondarily from extension of conjunctival flectin or rarely as a primary disease. It may present in two forms: ulcerative flectinolar keratitis, diffuse infiltrative keratitis. Fascicular corneal ulcer, diagrammatic and clinical. Ulcerative flectinolar keratitis may occur in following three forms: sacrophilous ulcer, Sacrophilous ulcer is a shallow marginal ulcer formed due to breakdown of small limbal flectin. It differs from catarrhal ulcer in that there is no clear space between ulcer and the limbus and its long axis frequent perpendicular to limbus. Such an ulcer usually clears up without leaving any opacity. Fascicular ulcer has a prominent parallel leash of blood vessels. Parallel leash. This is parallel leash. And miliary ulcer. This form multiple small ulcers are scattered over a portion of or whole of the cornea. Diffuse infiltrative flectinolar keratitis may appear in the form of central infiltration cornea with characteristic rich vascularization from periphery all around the limbus and may be superficial or deep. Clinical exposure is usually self-limiting and flectin disappears in 8 to 10 days, leaving no trace. However, recurrences are very common. Differential diagnosis. Flectinolar conjunctiva need to be differentiated from episcleritis, scleritis, congenital foreign body granuloma, etc. Presence of one or more whitish raised nodules on the bulbar conjunctiva near the limbus with hyperemia, usually of the surrounding conjunctiva in a child living in bad hygiene condition, or diagnostic features of flectinolar conjunctivitis. Management. It includes treatment of flectinolar conjunctivitis by local therapy, investigation, specific therapy aimed at eliminating causative allergen and general measure to improve health condition of the children. Local therapy. Topical steroids in the form of eye ointment, dexamethasone, betamethasone, antibiotic drops, and ointments. Atropine should be applied once daily if cornea is involved. Specific therapy. Tuberculosis infection should be excluded. X-ray chest, Montauk chest, TLC, DLC, ESR. Tubercular focus is discovered. Anti-tubercular treatment should be started with combat infection. To combat infection, septic focus in form of tonsillitis, adenitis, caries teeth when present should be adequately treated with systemic antibiotics. Parasitic infection should be ruled out by repeated stool examination when discovered should be adequately treated or completely eradicated. General measures. Attempts should be made to provide high protein diet supplement with vitamin C, A, C, A, D. Contact dermatoconjunctivitis. It is an allergic condition involving conjunctiva, skin of lids along with surrounding area of face. Etiology. It is in fact delayed hypersensitivity. A few common topical ophthalmic medications known to produce contact dermatoconjunctivitis are atropine, penicillin, neomycin, soframycin, gentamicin, etc. Cutaneous involvement is in the form of weeping eczematic reaction involving all areas which medication comes in contact. Congenital response is in the form of hyperemia with a generalized papillary response affecting the lower fornix and lower pulporal conjunctiva more than upper. Cornea may show punctate epithelial keratitis and erosions. Diagnosis. Clinical features is usually topical. Congenital cytology so lymphocytic response with mass of eosinophil. Skin test to causative allergen is positive in most of the cases. Discontinuation of causative medication. Topical steroid eye drops to relieve symptoms. Application of steroid ointment on involvement of skin. Cicatricial conjunctivitis. This one is ocular mucous membrane pemphigoid with inferior symblepharon formation. OMMP is thought to be a tied to ocular mucous membrane pemphigoid. Start to tied to reaction. Age usually occurs in after 60 years of age, involving basement membrane of epithelial cells of conjunctiva, other mucous surface, and even skin. 6. Slightly more common in female than men. Pathology: it is a chronic inflammatory subepithelial blistering disease with subsequent cicatrization of the involved mucosa. Ocular features: symptoms include incidence onset of bilateral redness, foreign body sensation, watering, and photophobia. Signs progress as below. Inflammatory signs include hyperemia, chronic papullae, congenital vesicles, which later ulcer. Cicatrization signs include loss of plica seminiferans, fornices, formation of symblepharon, usually inferior ancli blephron, sending in severe dry eye syndrome. Corneal involvement occurs as a superficial punctate characteristic, secondary microbial characteristics, corneal neovascularization, even perforation. Let's equally include trichiasis, entropion formation, etc. Systemic feature: mucosa of oral cavity, anus, vagina, and urethra may be involved. Desquamated gingivitis is more common association. Cutaneous vesicle, bullae, and scar formation may occur. Involvement of trachea and esophagus potentially life-threatening. Differential diagnosis need to be made from Stephen SJ syndrome. And treatment: topical treatment comprise tear substitutes, antibiotics, steroids. Systemic immunosuppression is typically required to suppress the acute phase of disease. Mild disease used dapsone, moderate disease used antimetabolics such as methotrexate, severe disease used intravenous methylprednisolone, etc. Surgical intervention requires in late stage may be punctal occlusion for dry eye, silicone hydrogel contact lens use, correction of tracheas and entropion, ocular surface reconstruction for advanced scarring, corneal transplantation, keratoprosthesis in extremely extensive corneal and ocular surface scarring, SJS syndrome, and toxic epidermal necrosis. Or acute mucovadinous blistering disease usually with severe ocular complications. These conditions are thought to result from type 3 hypersensitivity response to such drugs such as sulfonamide, anticonvulsant, allopurinol, etc. and infectious agents such as mycoplasma, pneumonia, herpes simplex, adenovirus, etc. Clinical features: symptoms include acute onset of fever, skin rash, red eyes, malaise, arthralgia, respiratory tract symptoms. Systemic signs: classic target skin lesions or maculopapulas with red crater white surrounding area bullae. Hemorrhagic inflammation of mucous membrane, hemorrhagic lip crusting, ulcerative stomatitis, slowing of epidermal surface seen in 10 is called Nikolsky sign. Ocular signs: acute disease characterized by papillary or mucopurulent pseudomembranous conjunctivitis, episcleritis, and iritis. Late disease characterized by congenital scarring, symblepharon, tracheal deformities, dry eye resulting from loss of goblet cells, destruction of lacrimal gland ductules. Corneal and neovascular ulceration, perforation, and scarring. Treatment: systemic treatment in acute phase include removal some causative drugs or treatment of causative infection, inciting factors, intravenous immunoglobulin, role of systemic steroids in controversial, maintenance of hydration, debridement, replacement of sulfingsin. Ocular treatment during acute phase include topical tear drops, prevention of exposure, topical antibody steroid drops, pseudomembrane peel, symblepharon lysis with glass rod or moistened cotton swab. Late stage interventions are similar to OMMP. Secondary cysarterial conjunctivitis, it is a secondary condition, and toxic conjunctivitis lead to conjunctivitis secondary to molluscum contagiosum. It is a type of chronic follicular conjunctivitis that occurs as a response to toxic cellular debris discombed into conjunctival sac from the molluscum contagiosum nodules present on the lid margin. Chemical toxic conjunctivitis is a irritative follicular conjunctival response which occurs after prolonged administration of topical medication. Common topical preparations with chronic follicular conjunctivitis are edoxyuridine, E-sarin, pilocarpine, DFP, adrenaline, etc. Degenerative conditions. Pincecula is extremely common degenerative condition of conjunctiva. It is characterized by formation of yellowish white patch on the bulbar conjunctiva near the limbus. This condition is termed pincecula. It is often differentially diagnosed with with pterygium, and this condition is termed as pincecula because of its resemblance to fat, which means pincus. Pincecula. Etiology of pincecula is not known. It is an age-related change, and it was considered as a precursor of pterygium. However, currently it is suggested that pingular does not progress to pterygium, and that are two distinct disorders, and two of them are differential diagnosed. Pathology: there is an elastotic degeneration of collagen fibers of substantia propria of conjunctiva, coupled with deposition of amorphous hyaline membrane in the substance of conjunctiva. Clinical feature: pingular is bilateral. Usually stationary condition, presenting as yellowish white triangular patch near the limbus. Apex of the triangle is away from the cornea. It affects the nasal side first, then temporal side. When conjunctiva is conjunctive, it stands out as avascular prominence. Complications of pingular include its inflammation, intraepithelial abscess formation, rarely calcification, doubtful conversion into pterygium. Treatment: in routine, no treatment is required for pingular. However, when cosmetically is unaccepted, and if so decided, it may be excised. Pterygium. Pterygium is a wing-shaped fold of conjunctiva encroaching upon the cornea from either side of the interpalpebral fissure. Etiology. Etiology of pterygium is not definitely known, more common in people living in the hot climates. Therefore, the most acceptable view is responsible for prolonged effect of environmental factors such as sun, ultraviolet, dry heat, high wind, abundance of dust. Pathology. Pathological pterygium is degenerative and hyperplastic condition of conjunctiva. Subconjunctival tissue undergoes elastotic degeneration and proliferation as vascularized granulation tissue under the epithelium. Vascularized granulation tissue, which ultimately enrolls the cornea. The cornea, epithelium, Bowman's layer, and superficial stroma are destroyed. Demography. Age usually seen in old age. Sex more common in males doing outdoor work. Laterality. It may be unilateral or bilateral, usually present on nasal side, may also occur in the temporal side. Symptoms. Cosmetic intolerance may be only tissue in otherwise asymptomatic condition. Foreign body sensation, irritation, effective vision as it encroaches the cornea, pupillary area, or due to corneal astigmatism induced by fibrosis in regressive stage. Diplopia may occur occasionally due to limitation of ocular movements. Signs. Pterygium presents a triangular fold of conjunctiva encroaching on the cornea in the area of palpable aperture, usually on the nasal side, but may also occur in the temporal side. Very rarely, both nasal and temporal sides are involved. Primary double pterygium. Parts of fully developed pterygium are as follows: head, apical part present on the cornea, neck, constrictor part present in the limbal area, and body, scleral part extending between limbus and canthus. Cap. Similar weight is infiltrated present just in the front of head. Types. Depending upon the progression, it may be progressive or regressive pterygium. Progressive is thick, fleshy, vascular with a few whitish infiltrates in the cornea in front of the head of pterygium, known as fuchs spots or islets of Vogt, also called a cap of pterygium. Regressive pterygium is thin, atrophic, attenuated with very little vascularity. There is no cap, but deposition of iron may be seen sometimes just anterior to the head of pterygium. It is known as Stoker's line. Ultimately, it becomes membranous but never disappears. Complications. Cystic degeneration, infection are infrequent. Neoplastic change to epithelioma, fibrosarcoma, malignant melanoma may occur rarely. Differential diagnosis. Pterygium may be differentiated from pseudopterygium. Pseudopterygium is a fold of bulbar conjunctiva attached to cornea. It is formed due to adhesions of chemosed bulbar conjunctiva to marginal corneal ulcer. It usually occurs following chemical burns of eye. Pterygium, pseudopterygium. Pterygium is a degenerative process. Pseudopterygium inflammatory process. Usually, pterygium occurs usually in elder patients, can occur at any age, always situated in the palpebral aperture, can occur at any site, either progressive or regressive or stationary, always stationary. Probe can be passed underneath neck. Treatment. Surgical excision, cosmetic disfigurement, visual impairment due to significant regular or irregular astigmatism, continued progression threatening to encroach into pupillary area. Diplopia due to interference in ocular movements. Recurrence of the pterygium. However, it can be reduced by any of the following measures: surgical excision with free congenital limbal autograft claw taken from the same eye or other eye present in the preferred technique. Surgical excision with amniotic membrane graft, metomycin, MMC 0.02% application may require in recurrent pterygium or when dealing with a very large pterygium. Surgical excision with lamella keratectomy, lamella keratoplasty may require in deeply infiltrating recurrent and recalcitrant pterygia. Old methods to prevent recurrence include transplantation of pterygium in the lower fornix, Mecranol's operation, and post-operative use of beta radiation. After topical anesthesia, Eye is cleansed, draped and exposed using universal eye speculum. Head of pterygium is lifted and dissected off the cornea very meticulously. Main mass of pterygium is then separated from the sclera underneath. Congenital and superficial pterygium tissue is then excised, taking care not damage and underlying medial rectus muscle. Hemostasis is achieved by episcleral tissue cauterization. Congenital limbal autograft transplant to cover the defect after pterygium excision. It is latest and most effective technique in the management of pterygium. Use of fibrin glue stick to autograft in place reduce operating time as well as discomfort associated with sutures. Concretions. Etiology. Concretions are formed due to accumulation of inspissated mucus and dead epithelial cell debris into congenital depression called loops of Henle. They are also seen in elderly patients in degenerative condition, or also in patients with scarring stage of trachoma. The name concretion is a misnomer as they are not calcareous deposits. Surgical technique of pterygium excision. Dissection of head from the cornea. B. Excision of pterygium tissue under conjunctiva. Excision. And C is a congenital limbal autograft after excision in the pterygium. Clinical features. Concretions are seen on the parapral conjunctiva, more commonly in the upper fornix. These are yellowish white hard looking raised areas varying in the size from pinpoint to pinhead. Being hard, they may produce foreign body sensation, lacrimation by rubbing the corneal surface. Occasionally they may even cause corneal abrasion. Treatment. It consists of their removal with help of hypodermic needle under topical anesthesia. Amyloid degeneration conjunctiva. Primary congenital amyloid is associated with deposition of light chain immunoglobulin by monoclonal B cells and plasma cells. Secondary congenital amyloid may occur secondary to systemic disease or secondary to chronic congenital inflammation. Clinical feature. Deposition of yellowish well demarcated irregular amyloid material in conjunctiva with superior fornix and dorsal conjunctiva being more common involved areas. Congenital hemorrhage may associate with amyloid deposition in blood vessels. Treatment. Lubricating drops for mild symptoms. Excision biopsy can be performed in patients with marked irritation due to raised lesions. Hyperemia conjunctiva, symptomatic condition conjunctiva, chemosis conjunctiva, ecchymosis, xerosis, discoloration. Simple hyperemia of conjunctiva. It means congestion of conjunctival vessels without being associated with any of the disease. Etiology. One is acute transient hyperemia, which results due to temporal irritation caused by direct irritants such as foreign bodies, dust, chemical smoke, chemical fumes, stormy wind, bright light, etc. Reflex hyperemia due to eye strain from inflammation of nasal cavity, lacrimal passage inlets. Hyperemia associated with systemic febrile condition, non-specific inflammation of conjunctiva. Recurrent or chronic hyperemia. It is often noticed in chronic smokers, chronic alcoholics, people residing in dusty, ill-ventilated rooms, workers exposed to prolonged heat, in patients suffering from rosacea, insomnia, and otherwise having less sleep. Clinical feature. Patient with simple hyperemia usually complain of feeling of discomfort, heaviness, grittiness, tiredness, tightness in the eye. There may be associated with mild lacrimation, minimal mucoid discharge. On cursory examining the conjunctiva, the conjunctiva often looks normal. However, eversion of lids may reveal mild to moderate congestion, being more marked in fornices. Treatment. Removal of the cause of hyperemia. Example, in acute transient hyperemia, the removal of irritants. Example, misdirected cilia gives prompt relief. Symptomatic relief may be achieved by use of topical decongestion. 1:10,000 adrenal drops or navosodine drops. Chemosis of conjunctiva. Chemosis or edema of conjunctiva is frequently the common cause of chemosis can be grouped as local inflammatory condition. These include conjunctivitis, ulcers, fulminating iridocyclitis, endophthalmitis, panophthalmitis, acute meibomitis, orbitocellulitis, acute dacroadenitis, acute dacrocystitis, etc. Local obstruction of blood and lymph. It may occur in patients with orbital tumors, cysts, endocrine subtherms, etc. Systemic causes include heart failure, hyperproteinemia, etc. Clinic vision management largely depends on causativity. Ecchymosis of conjunctiva. It's a very common occurrence. Subconjunctival hemorrhage. It may vary in extend from small petechial hemorrhage to expansive one spreading under wall of bulbar conjunctiva and thus making the white sclera of eye invisible. The condition though draws the attention of most patients immediately as an emergency but is most common and trivial. Subconjunctival hemorrhage may associated with following conditions: trauma. It is the most common cause of subconjunctival hemorrhage. It may be form of local trauma to conjunctiva, including that due to surgery, subconjunctival injection, retrobulbar hemorrhage which almost immediately spreads below the bulbar conjunctiva. Mostly it results from retrobulbar injection, most from trauma involving various walls of the orbit. Inflammation of conjunctiva. Petechial subconjunctival hemorrhages are usually associated with acute hemorrhagic conjunctivitis caused by picornavirus, pneumococcal conjunctivitis, leptospirosis, icterohemorrhagia conjunctivitis, sudden venous congestion of head. The subconjunctival hemorrhage may occur owing to rupture of conjunctival capillaries due to sudden rise in pressure. Common conditions are whooping cough, epileptic fits, strangulation or compression of jugular veins, and violent compression of thorax, abdomen as seen in crush injuries. Spontaneous rupture of fragile capillaries may occur in vascular disease such as arteriosclerosis, hypertension, diabetes mellitus, etc. Local vascular anomalies like telangiectasia, varicosities, aneurysm, angiomatous tumor, blood discrepancies like anemia, leukemia, dysproteinemia, etc. Bleeding disorders like purpura, hemophilia, scurvy, acute febrile systemic infections such as malaria, typhoid, diphtheria, meningococcal septicemia, measles, scarlet fever. Viscerous bleeding associated with menstruation is an extremely rare cause of subconjunctival hemorrhage. Clinic which subconjunctival hemorrhage per se is a symptomless. However, there may be symptoms associated with causative disease. On examination, subconjunctival hemorrhage looks as a flat sheet of homogeneous bright red color with well-defined limits. In traumatic conjunctival hemorrhage, posterior limit is visible when it is due to local trauma to eyeball, not visible when it is due to head injury or injury to orbit. Most of the time, it is absorbed completely within 7 to 21 days. During absorption, color changes are noted from bright red to orange, then yellow, and subconjunctival hemorrhage. Treatment. The cause when discovered placebo therapy with astringent eye drops. Psychotherapy assurance to patient is most common part of treatment. Cold compress to check bleeding in the initial stage. Hot compress may help absorption of blood in later stage. Zeros of conjunctiva. It's symptomatic condition in which conjunctiva become dry and lusterless. Conjunctiva kept moist by its own secretion, mucin from global cells, aqueous solution from axillary lacrimal cells, gland. Therefore, even if the main lacrimal gland is removed, xerosis does not occur. Depending upon etiology, congenital cirrhosis can be divided into two types: parenchymatous and epithelial type. Parenchymatous xerosis and epithelial xerosis. Parenchymatous xerosis occurs in the following cicatricial disorganization of conjunctiva due to a local cause, which can be in the form of destructive interstitial conjunctivitis as seen in trachoma, diphtheric membrane conjunctivitis, Stevens-Johnson syndrome, pemphigus or pemphigoid conjunctivitis, thermal, chemical or radiation burns of conjunctiva. Exposure to conjunctiva air has seen marked degrees of proptosis, facial palsy, ectropion, lack of blinking, lack of ophthalmos due to semblipheron, etc. Epithelial xerosis. It occurs due to hypovitaminosis A. Epithelial xerosis may occur associated with night blindness or as part and parcel of xerophthalmia. The term which is applied to all ocular manifestations of vitamin A deficiency, which range from night blindness to keratomalacia. Treatment. Epithelial xerosis typically occurs in children and is characterized by varying degree of conjunctival dryness, thickening, wrinkling, and pigmentation. Treatment of the cause. Symptomatic local treatment with artificial tear preparations, methylcellulose, hypermethylcellulose, polyvinyl alcohol, etc. Discoloration of conjunctiva. Conjunctival red discoloration, yellow discoloration, greyish discoloration, brownish discoloration, blue discoloration, brown pigmentation, which include non-melanocytic pigmentation, endogenous pigmentation in Addison disease, exogenous in glaucoma. It may follow due to long-term use of retinal glaucoma. Argyrosis may present as dark brown pigmentation, melanocytic pigmentation, congenital epithelial melanosis, red discoloration in subconjunctival hemorrhage, yellow discoloration, bile pigments in jaundice, blood pigments in malaria, yellow fever, congenital fat in elder negro patients. Raised discoloration occur due to application of kajal, mascara, brownish eye due to argyrosis, prolonged application of silver nitrate in chronic congenital inflammation. Blue discoloration is usually due to ink tattoo from pens or effect of manganese dust. Subepithelial melanocyst, pigment tumors. Cysts of conjunctiva. Congenital cystic lesion, lymphatic cysts of conjunctiva, retention cysts. Lymphatic cysts are usually due to dilation of lymph space in bulbar conjunctiva. Lymphangiectasis is characterized by a row of small cysts. Rarely, lymphangioma may occur in single multilocular cyst. Retention cysts. These occur occasionally due to blockage of ducts of accessory lacrimal glands of Crossy in chronic inflammatory condition. Congenital melanosis occurs. Cysticercosis of conjunctiva. The common fibrosis retention cysts are more common in upper fornix. Epithelial implantation of traumatic cyst, congenital epithelial melanosis, due to surgical or non-surgical injuries of conjunctiva. Epithelial cysts due to downgrowth of epithelium are rarely seen in chronic inflammatory or degenerative changes. Cystic change in pterygium. Aqueous cyst, it may be due to healing by cystoid cystic formation following surgical or non-surgical perforation limbal wounds. Pigmentary epithelial cyst, it may be formed sometimes following prolonged topical use of cocaine or epinephrine. Parasitic cysts such as subconjunctival cysticercus, hydrated cysts, failure cysts are not frequent in developing countries. Congenital cysts need to be careful surgical excision. The excised cysts should be always subjected to histopathology examination. Tumors of congenital, benign, pre-malignant, malignant, congenital dermoid, lipodermoid, benign, simple granuloma, papilloma, adenoma, fibroma, angioma, intraepithelial epithelioma, epithelioma, squamous cell carcinoma, basal cell carcinoma, pigmented tumors, benign, naive and congenital moles, precancer melanosis, superficial spreading melanoma, lentigo maligna, and malignant primary melanoma. Congenital tumors, dermoid consists of are common congenital tumors which usually occurs at the limbus. They appear as solid white mass firmly fixed to the cornea. Dermoid consists of collagenous connective tissue, sebaceous gland, hair, etc. Lipodermoid is a congenital tumor usually found at the limbus or outer canthus. It appears as soft yellowish white movable subcongenital mass. It consists of fatty tissue surrounding dermis like connective tissue. Benign tumor, simple granuloma. It's a cauliflower-like growth of granulation tissue. Simple granuloma common following squint surgery as foreign body granuloma and following inadequate scraped chalazion. Squamous epithelial carcinoma, limbus, lipodermoid, limbal dermoid. Treatment: papilloma. Treatment consists of complete surgical removal. Papilloma is a benign polypoid tumor usually occurring at inner canthus fornix limbus. It may resemble the coxcomb type of congenital tuberculation. Fibroma, it is a soft, hard polypoid growth. Premalignant tumor, Bowen's intraepithelial epithelioma, carcinoma in situ. Rare precancer condition now including ocular surface squamous epithelium. Neoplasia, squamous cell carcinoma. It usually occurs in the transit zone, that is at limbus, the lid margin, and the tumor invades the stroma deeply and may be fixed to underlying tissues. Histology, it is similar to squamous cell carcinoma occurring elsewhere. Now it is also included in ocular surface squamous neoplasia. Ocular surface squamous neoplasia is a term coined to denote the wide spectrum of dysplastic changes involving the epithelium of congenital cornea limbus. It includes squamous dysplasia, carcinoma in situ, that is corneal congenital intraepithelial neoplasia, squamous cell carcinoma. It is characterized partial to full thickness intraepithelial neoplasia with an intact basement membrane, while SCC occurs when neoplastic cells penetrate the basement membrane and invade the underlying stroma. Very few CAN progress to SCC. Risk factors: pathogenesis. Since OSSN also occurs in limbus, it has been postulated that various predisposing factors probably act on stem cells, causing abnormal maturation, proliferation, resulting in OSM stem cell theory. Clinical features: leukophilic form, papillomatous form, gelatinous form. Treatment: surgical excision. Measures to decrease recurrence include cryotherapy, topical chemotherapy with mitomycin 0.002%. Basal cell convoy, it may be invade the congenital from lids or may arise peripasso from the plica, similar as congenital nevus. Pigmented tumors, naive or congenital nevus, congenital mode. They are a common pigmental lesion, usually presenting on grey, gelatinous, brown or black, flat or slightly raised. They usually appear during childhood and may increase in size at puberty during pregnancy. Malignant change is very rare when occurs in They indicated by sudden increase in size or increase pigment. Therefore, excision is usually indicated as for cosmetic lesion. Whatever may be the indication, excision should be complete. Precancerous melanosis. Clinically, small pigment tumor develops at any site of bulbar or purple conjunctiva. Diffuse flat pigment patch. Treatment. Postoperative radiotherapy may be efficient. Malignant melanoma. Clinically may present a pigmented non-pigment mass near limbus, part of conjunctiva. Histologically, neoplasm may be alveolar. Treatment, once suspected, inoculation or excision is treatment of choice depending upon the extent of growth. Thank you.